Okay, so today we're going to go ahead and talk about the patient who comes in with blunt abdominal trauma. This lecture will give you an algorithmic approach to these patients so that you can feel confident when they come in. So the first thing we're going to do, which is the same thing we do for any other trauma, is divide abdominal trauma into two main categories. The first category is penetrating trauma. And you can go to the website to see our lecture on the approach to a patient with that type of abdominal trauma. But today we're going to focus on the second category, which is blunt abdominal trauma. The approach to these patients can be a little tricky, so let's go ahead and zoom in and get started. The first thing that you're going to want to ask yourself is, how is my patient doing from a hemodynamic standpoint? To answer this question, you want to look at the patient's heart rate and see whether or not they're in fact tachycardic, or you'll want to look at their blood pressure and see whether or not they have a stable blood pressure or if they're in fact hypotensive. And based on all of this objective data, we'll go ahead and place the patient into one of three categories based on their hemodynamic status. So the patient will either be stable, unstable, or in a category I like to call the I am not 100% sure whether they're stable or unstable. The patient may be a little tachycardic but have stable blood pressures. So they're kind of in that in-between area. So let's start with the easy one. If the patient is unstable, they should go straight to the operating room for definitive management. If they're in this category, then things get a little bit more interesting. The next step for this patient would be to begin aggressive resuscitation with blood transfusions. At the same time, it's important to try and figure out where the patient is bleeding from. So a fast exam or a DPL can be performed to try and see if there's any free fluid in the abdomen that could be blood. After initial resuscitation, the patient should now be reassessed, looking to see whether or not their vital signs have stabilized or if their exam has changed in any way. If the patient is now stable, then that's good news, and you can have more time to kind of work up what exactly is going on. This is generally done by taking the patient down to the CT scanner to see what type of injuries are present. The patient can then be admitted, but at least now you know where the injuries are and what needs to be managed more aggressively. If the CT looks really bad, the patient can then just be taken to the OR. If on reassessment the patient is now unstable or still tenuous, then at this point the patient should be taken straight to the operating room. If you do in fact try to take this patient down to the CAT scanner, they may in fact code, and that would be bad. With that said, at least the surgeons will have information as to whether or not there is in fact bleeding in the belly, which was determined either by your fast exam or your DPL. I also want to point out that this is the patient that you should be doing the fast exam on. In sicker patients, there is probably more blood in the abdomen, which will make it easier for the fast exam to detect it and increase the sensitivity of the exam. Now let's focus on the patient who's hemodynamically stable. The next question to ask yourself is there any abdominal tenderness or peritoneal signs on exam? If the answer to that is yes, then the patient should undergo a CAT scan. If the CAT scan is positive, then the decision's easy. The patient should probably be admitted, and if necessary, can be taken to the OR for definitive management. But what do you do if the CAT scan is in fact negative? Can you just discharge the patient home? And the answer to this is you would actually want to keep them in observation. This is because CAT scans aren't great at picking up hollow viscous injuries or pancreatic injuries. So if after the observation period the patient develops abdominal pain, then you can go ahead and admit them. But if their exam is stable or they have improved symptoms, then you can in fact discharge them home. If the patient has no abdominal tenderness to palpation, then what do you do? The best practice would be for you to in fact admit this patient to observation as well. In observation, the patient can have serial abdominal exams and serial hematocrits drawn to make sure that you're not missing an early hollow viscous injury, as well as a pancreatic injury. Now, another important question would be, how long do we need to obs these patients? Unfortunately, the guidelines don't really give us any guidance to answer this question. So as a result, it's probably best to just kind of check with your institution to see what their protocol is. Also, CAT scans are getting better, so these guidelines could change to where it's no longer necessary to actually keep these patients in observation. And that's about it. So hopefully this will help give you some guidance when you face these challenging patients. Thanks for watching.